Шановні колеги, шановні
Dear
друзі,
colleagues, dear friends, we are happy to welcome you at day 2 of our 13th webinar on track to improve health of women living with HIV in Ukraine. And this webinar is done by the working group of European AIDS Clinical Society, EX, and WAVE, which is Women Against Viruses in Europe working group. And our webinar is about women who live with HIV. And this is truly the 13th meeting that we are having today, day 2. And for those who failed to join us yesterday, just a reminder, yesterday there was day 1 of our webinar. We talked about new strategies in ART in women. If you couldn't join yesterday, there is a recording, and there'll be recordings available both for day 1 and 2 for a couple of more weeks at YouTube channel of EX. And today we are going to discuss modern approaches to reproductive health and ART in women. And just for the beginning, I would like to introduce our chairs, Caroline Abby Bob, doctor, consultant, obstetrician, gynecologist, researcher, Department of Infectious Diseases, University Hospital Bern, Switzerland, and Svetlana Antoniak, infectious disease doctor, honorary doctor of Ukraine, researcher at HIV/AIDS and Viral Hepatitis Department, Institute of Epidemiology and Infectious Diseases, with National Academy of Medical Sciences, Kyiv, Ukraine. And I would like to give the floor to our chairs for their welcome word. Ms. Svetlana, you're most welcome. Dear colleagues, I am very pleased to welcome you to the 13th WAVE-EX webinar on track to improve the health of women living with HIV Ukraine. And sincerely thank you for your interest and for finding the time, despite of all the challenges of today and your busy schedules, still you found time to participate and discuss important issues related to modern approaches in reproductive health and ART, with a special focus on the needs of women. Traditionally, I would like to express my warmest gratitude to Doctor of Medicine Caroline Abby Pop, Master of Science, who works as a consultant, obstetrician, gynecologist, and researcher in the Department of Infectious Diseases at the University Hospital of Bern, Switzerland. And she is going to give mini lecture, Reproductive Health in Women Living with HIV. So we will discuss it today. And it was actually Caroline Abipop together with Professor Justyna Kowalska of Medical University of Warsaw and Professor Fiona Mulcahy, who worked at St. James Hospital in Dublin, who inspired us back in 2018 to hold the WAVE-EX webinars on track to improve the health of women living with HIV Ukraine. Caroline Abipop has been actively involved in the development and implementation of many clinical studies in the field of HIV in women in collaboration with the Swiss HIV cohort study and the European Joint Study. And she was developing recommendations on pregnancy and childbirth for women living with HIV in Europe. Her research interests also include breastfeeding and menopause in women with HIV. We are very grateful to all the speakers and our whole panel for continuing to help Ukraine. We would like to express our gratitude to Ms. Harriet Langanke, a sexologist, a journalist, and with a special focus on the needs of women and female sex workers, who is the editor-in-chief of Germany's first and only magazine on women's health and sexual health, Diva. She lives and works in Cologne, Germany, and since 1991, she had a clear focus and still having a clear focus on women in her professional work. As clinicians working in the field of HIV care, we understand the importance of openly discussing issues of fertility, contraception, menopause with our patients. But a question is, do we always do this in our routine clinical practice? And do we always do it right? So practical strategies that help doctors create atmosphere of trust when collecting sexual history from women with HIV are really very important to us. And we hope that Harriet Blanganka's lecture and discussion will help us improve communication and improve care for women living with HIV in our daily practice. We support the evidence-based strategy U equals U, and we understand how difficult it was at the beginning of its implementation to implement it in the beginning. But even today, the strategy requires more thorough and correct implementation and explanation. Many thanks to Dr. Nadia Zhilkam. She is a professor at the Department of Obstetrics and Gynecology at National University of Health. She is also an international expert on reproductive health, who, despite her busy schedule, found time to participate in our webinar and provide an overview of the situation and challenges in the field of reproductive health in Ukraine. Also, we are very grateful to Olga Klimova, an infectious disease specialist at the Public Health Center at the Ministry of Health Ukraine, who prepared a very interesting presentation entitled Women and HIV on Track to Healthy and Long Life Ukraine, with very interesting data on the specifics of the treatment and care cascade of women with HIV in Ukraine. We also welcome Mariana Svider, an obstetrician gynecologist at the Ivano-Frankivsk Regional Perinatal Center, who will also participate in discussion. And Ms. Mariana is also the secretary of the working group on elimination of vertical HIV transmission. And the interest of Ukrainian doctors in the webinar focusing on important health issues for women living with HIV remains high. Many thanks to all the participants from Ukraine for continuing their work despite the difficult days, air raid alerts, and sleepless nights. And we realize that it's important to take into account the needs of people living with HIV and to continue providing assistance today, even under martial law in Ukraine. This is a testament to the resilience, consistency, continuity, and that we all need so much. Today, we are focusing on important issues related to modern approaches to reproductive health and ART, with a special focus on the needs of women. Today's moderator is Serhiy Antonyak, a research associate at the Department of Viral Hepatitis and HIV at the Institute of Epidemiology, Infectious Diseases Clinic. Also, he is a member of WAVE Scientific Committee. And now I'm giving the floor back to Serhiy. Thank you. Thank you, Ms. Svetlana. Yes, dear colleagues, it's truly, we have a busy agenda for today. Thank you, dear speakers who joined us today. And now I would like to remind that our participants, our viewers, is an indispensable part of our whole process of our webinar. So we will be very grateful if you put your questions in our chat, and we will try to answer as many questions as possible. Also, I would like to remind you that after today's session, the actual questionnaire is going to be available to you, and this is not to assess your knowledge, but to inquire about your experience, about the quality of our webinar. And after you fill it out, you will get a participant's certificate. So yes, we have a really busy schedule. That's true. So this is our first mini lecture. This is reproductive health in women living with HIV. That's going to be given by Caroline Abbey Pop.
Thank you very much. I would like to give you a little talk about reproductive health and contraception in women living with HIV. I have no conflicts of interest in regard to this talk. First of all, contraception is important to prevent maternal and neonatal mortality because undesired pregnancy are a main reason for that. Second, birth control is estimated to reduce maternal deaths by 44%, and there's still about 270,000 deaths per year averted through contraception. In addition, 1/3 of maternal deaths could be prevented if there would be the full demand of contraception met worldwide. And hormonal contraception, unlike barrier methods, does not protect against sexually transmitted infections. This is a really important thing we should consider when we provide contraceptives. So unplanned pregnancies, according to HIV status, you can see here that still there's more unplanned pregnancies in women living with HIV. And sometimes, of course, this ambivalent desiderium that women do not know if they should keep that pregnancy, but it's a really high issue. And we did 2 publications about the neglect of attention to reproductive health in the Swiss HIV cohort study. And we saw that time, that is a study a while ago, 7 years, but we saw that in 74% condoms were used as contraceptive. And oral hormonal contraception was only used in 10%, intrauterine device also 10%, and we had 20% unplanned pregnancy in Switzerland. And then we were thinking of, after U equal U, condoms are not necessarily to have to be used in a stable partnership. So what should you give to women living with HIV? First of all, we have to understand how hormonal contraception is being effective. First of all, progestin, they do vary between levonorgestrel, etonorgestrel, norgestimate. They are actually responsible for the contraception. They will thicken the cervical mucus, and they will also, most of the time, inhibit ovulation. The tolerability, that is the reason we provide combined contraceptives. So we add estrogen to make the progestin more easy to use, because estrogen stabilizes the endometrium, and this is important also for women to have a regular period. So we really have to understand this, because always progestin is responsible for the contraceptive effect, and estrogen is given in addition to make the contraceptive more tolerable. So we have different routes of administration. You all know that we have the intrauterine device that has to be put by a gynecologist. We have the implant in the upper arm, and we have the injectables every 3 months or every 10 weeks, better. So the doses and the indications are very, very different. We also, you can see on the right-hand side, we have the combined products. On the one hand, the contraceptive pill, you have to take 21 tablets, and then 7 days of a break, again 21 tablets every day. We have the patch that is used weekly, and we have the vaginal ring that is also combined method to be used for 3 weeks, and then there's 1 week of a pause. We know that contraceptions can fail, of course. Like everything in life can fail, contraceptives might have failure rates. And you can see here that the implant and the intrauterine device and the injectables have really low rates of failure, because you don't have to think about to use them. Of course, if an implant is set in the upper arm, it's there for 3 years. And if an IUD is set, like the Mirena IUD, it can stay for even 8 years. Whereas the pill is prone to be forgotten sometimes, and that makes the failure rate higher. I think the male condoms have also a high failure rate, and I'm sure it's depending by age and by partnership. There are some stable partners. They are doing contraception for 10, 20 years with condoms, and they have never a failure. But younger people might have more failure, or casual partnerships might have more failure rates. So of course, withdrawal and periodic abstinence have high failure rates, up to 1/3 of unwanted pregnancies. So there are special considerations in regard to women living with HIV. First of all, most of the gynecologists did not provide contraceptives in Switzerland, especially combined oral contraceptives, because of fear of drug-drug interactions. We have fears of effects on HIV transmission, on HIV acquisition, and there's also some conflicting results about effects on HIV progression. So first of all, it's really hard to look at studies and research because unintended pregnancy is an ultimate outcome. So most studies, they use, for example, ovulation in ultrasound to say this contraception is not effective. Then there's also a really high individual variability in hormone concentrations. So we do not have a threshold, a pharmacological threshold of a value that will ensure contraceptive effectiveness. So this is very special because individuals do react differently if you give them hormones. That makes research in terms of contraception quite challenging and difficult. So drug-drug interactions. First of all, estrogens and progestins are metabolized by the well-known cytochrome P450. And so we have to know that in terms of interactions with the antiretroviral therapy. So there's lower progestin levels in some points. And as you remember, I said progestin is responsible for the effectiveness. So you have to see if progestin is lower, that might impact on effectiveness. But if progestin is higher and lower or higher estrogen levels, so there might be adverse effects like nausea or headaches, but there's no impact on contraceptives. It's always good to consult the HIV drug interaction table of the Liverpool database. And as you can see here, that most of the used drugs nowadays, they will cause lower estrogen levels in contraception. But as I told you, this might cause only irregular bleeding, but this might not cause unwanted pregnancies. And if norgestimate levels, that is a progestin, are higher because of interaction, that can cause side effects like nausea and edema. The integrase inhibitors are very well tolerated. There's no known drug-drug interaction with hormones, and you can also provide PrEP to women taking antiretrovirals. We look also at the emergency contraceptions, and this is very important that emergency contraception lowers a little bit the levonorgestrel levels, but this should be fine normally to still work. And we look also at non-oral hormonal contraceptives, and of course the intrauterine device with progestin is very well used and very safe. The injectables, I will show you some slides, are effective, but they are not maybe the best option for women living with HIV. So here we can see that still boosted BIs can lower the estrogen levels, and here we can see efavirenz, which is rarely used, can lower progestin levels. That might have an impact on effectiveness. There's a very recent Cochrane database, a systematic review. This is from this year, in June 25. There were 4 trials with nearly 10,000 participants across 4 countries looked at, and they looked at the long-acting contraceptive injection compared to an implant and compared to copper IUD, and they found a probably slightly increased risk of HIV acquisition. You might know the older studies that looked at that, and this is that women might acquire HIV more when they use one of those long-acting contraceptives. The IUD and the implant with levonorgestrel, there was little to no difference in HIV acquisition. The evidence is very uncertain still, 25, but we should look about the effect of this DMPA injection compared to net and non-HIV acquisition. So what are the mechanisms being responsible for that? The thing is that women have, when they acquire HIV, it has to be by viral invasion through the non-keratinized squamous epithelium in the vagina. And this is really important because actually this has to be intact. There could be no damage in this epithelium, and it's normally filled with mucus, providing a barrier against viruses. This is here. And the problem here, if the estrogen is dominant, this is very good. And if the progesterone is dominant in hypoestrogenic environment, you can see that the epithelium is not that smooth and not that closed. And so the thing is that DMPA might cause a hypoestrogenic environment, and that is responsible for the more likeliness to acquire HIV, to make the vaginal epithelium more prone to let the viral invasion. So this is a problem, and I show you because women with HIV across the world are aging, and we need to use contraceptives until they are at least in menopause. That means 1 year, no period, or 2 years, no period before 50. So this is a long time, and you know as well that not every contraceptive is good if you're over 40, because the progestogens and the risk for venous thromboembolism is increases about 50% if they use a combined method. So oral contraceptives will increase the risk by 50%. And if you look at oral estrogen, as I said, this is significant elevated by using the contraceptive pill, for example, and transdermal estrogen, which we use for menopause. There's no increased risk of venous thromboembolism. This is really, really important to know. And vaginal estrogens, there's also no risk for thrombosis. So we should offer all women over 45 who have problems with their vaginal mucosa local estrogens because they improve the tissue. There's reduced symptoms like itching and burning. Intercourse gets more comfortable. And it's really, really a win-win situation because there's no risk for the women. It does not cause an increase, for example, increased breast cancer risk if you use low-dose vaginal hormones. So in summary, we could say, first of all, most contraceptives are well tolerated and safe in women. So we should really offer contraceptives in younger years, especially the combined ones, but also the intrauterine devices. So most antiretrovirals do not limit the effectiveness of contraception. And we should always, in women over 40 years old, we should consider the venous thromboembolism risk. And we use, for example, progestogen-only variants. And we can still add, if they have symptoms, we could still add transdermal estrogen because it has no risk for thromboembolism. And the other thing is that is the last point that was already visible now. The long-term vaginal estrogen is safe for nearly all women. So only if they have breast cancer, you might abstain from that. You use lubricants and you use moisturizers. But you can use local vaginal estrogen to make the mucosa more resistant for infections. You can use that twice weekly. Normally it's used for many years. So thank you very much for your attention, and I'm looking forward to your questions. Thank you.
Я дуже дякую, Caroline.
Thank you so much, dear Caroline, for this wonderful presentation and for your support. And this is an ongoing support to all our webinars. I was very much impressed by the fact that contraception is critically important to decrease maternal mortality up to 44% of cases of maternal deaths can be averted, and even 29% more can be averted if the full need of contraceptives is covered. That's really very important. Contraception is very relevant until menopause starts, and then after menopause, local estrogen therapy, safe estrogen therapy improves life and health of women. It's true that after we have the evidence, and for a couple of years since the U equals U strategy has started to be implemented, and we know about U equals U, undetectable, untransmittable, in stable discordant couples, condoms frequently not used. So other methods of contraception have to be chosen. And it's really nice that the majority of contraceptives are quite safe and well tolerated, safe for women on combined ART, and it's worthwhile to offer hormonal contraception to women. Also, I would like to say, and Olga Klimova will talk about it later as well, that the majority of ART regimens for the majority of our patients, female patients including women, include integrase strand transfer inhibitors instead. So fortunately, there is no DDIs between dolutegravir and NRTIs and contraceptive methods, non-existent. So there is no DDAs, and the majority of drugs do not diminish the efficacy of contraception, and vice versa. Contraception does not impact ART regimens that have integrase inhibitors in them. If a woman is on efavirenz, although we are switching our women from efavirenz to other drugs, we refer everyone to Liverpool database, where you can see what DDIs can be expected of efavirenz. Well, maybe some decrease in hormonal contraception concentrations. At that website, we can have a look at that. If a woman is on protease inhibitors and if she has previous failures on boosted PIs, also we can have a look. We can look up at DDIs, what kind of hormonal contraception can have with protease inhibitors. So in general, that's a wonderful, very useful presentation, and I would like to ask Sergey for him to have a look at the chat, whether there are some questions. Yes, dear Svetlana, we do have a question in our chat. And I think it's going to be a question to Ms. Mariano. What kind of non-barrier hormonal contraceptions are the most popular and most accessible, affordable for Ukrainian women? And also we would like to hear your comments with regards to the lecture as well. Dear colleagues, good afternoon. First of all, I would like to thank Svetlana for inviting me. It's my pleasure. I'm very happy to see you all. Number two, I would like to thank Ms. Caroline. It's a truly informative presentation, lots of data, lots of useful data. So women living with HIV after consultation with a doctor, they can choose from several methods of contraception. In particular, young women, it's better, of course, it's better for young women if they have one sexual partner, oral contraceptives are better. And if they are tested because they have reproductive plans, so they would like to get pregnant, they can stop oral contraception and get pregnant. Women who completed their reproductive plans, or they are 40 plus, or they are closer to menopause, for those who have excessive bleeding, endometrial hyperplasia, for example, for those women, it's better to use levonorgestrel containing intrauterine device or injectables, because they have long-term action, long-acting. It's not like pills that you stop the pill and then you get pregnant. With long-acting thing, it's different. And if you have IUD, then it's much better going into menopause. For young women, for example, if there is no contraindication to contraception device, but it's a treatment system as well. If there is no contraindication for this type of contraception, then it's better if it's the intrauterine device, it's copper containing, or if it's not copper containing, then still oral contraception. And then another, well, and the question was, can you say again? So yes, of course. The question was, what are the non-barrier, which is hormonal contraceptives, are the most accessible, affordable, and most popular among women in Ukraine? So in fact, it could be one phase, two phase, biphasic, triphasic. So for young girls, a little dose of estradiol, 0.02, and women after 30, so 0.03, a higher estradiol for older women. And price-wise, they're very affordable. Some are not as affordable. Some contraceptives are given just for treatment. I'm not going to name brands to avoid conflict of interest. So also contraceptives can differ not with regards to estrogen, but progestogens as well. So some of them can lead to acne, some of them can lead to kind of depressive states depending on the dose. Some can lead to dryness in vagina. Then you should use the lubrication and moisturizers during sexual life, during sex in general. In some regions of Ukraine, so far there are free of charge oral contraceptives in some clinics that we provide to patients free of charge. Usually we give it to women after delivery, after childbirth. We have free of charge copper containing IUDs and oral contraceptives. Thank you so much. Thank you, Ms. Mariana. Thank you very much. And hopefully, yes, that this availability, yes, will continue, that we will continue to have them for our women. Thank you. Thank you. We have another question, and you partially already gave answer to that, but maybe there are some details. So what can you say about the pros and cons of contraception like implants, IUD, and injectables, if you compare them? So those are different contraceptive methods. IUD, if we talk about IUD, if there is no problems with cervix, no stricture, so technically it's easy to put it, yes, it's the easiest way. So a woman comes for a consultation, for a visit, no contraindications like STIs, for example, vaginal discharge, colpitis, vaginitis, cervicitis, she can be recommended IUD. So it's just 3 minutes, no pain, and IUD is inserted. And if it's the usual IUD, it's for 3 years. If it's levonorgestrel containing IUD, it's 5, 7, or even 8 years. That's the most simple thing. Injectables is just one injection per 3 months, and that's all. But in injection methods, if it's the injection, on the other hand, with IUD, there is 1 month of getting used to it, maybe some discharge or maybe some excessive discharge, but then it subsides totally. Sometimes it happens if a woman is small, very lean, poor nutrition maybe, so she might not have any bleeding or maybe just spotting. For implants, sometimes it could be intramenstrual bleeding and more dryness and more side effects. So for young girls, it's not always that we would recommend injectables. And oral contraceptives is the easiest. With regards to implants, one nuance, you have to come to see a doctor because it's inserted surgically. So into the upper part of the arm, you have to put the capsule in there, inside, and usually it's put there for 3 years. But to stop this contraceptive, to stop it working, again, you have to come to a doctor and then remove it. Thank you. Yes, each contraceptive has its pros and cons, advantages, disadvantages. So that is why you have to come to your OBGYN for consultation to choose the optimal. Sometimes a woman just wants an IUD and nothing else, and then they provide IUD, but a couple of months later she comes, no, I don't like it any longer. It happens, yes. Yes, that's true. Yes, because women do not always can imagine how it feels and what's happening, how it's going to be, or maybe pain might happen, right? In fact, each woman, perceives IUD differently because they have different sensitivity, tolerability. So it's very individual. Thank you. Thank you. Thank you, Ms. Mariana. Dear colleague, so I'm going to keep an eye on time to stick to our agenda. What I suggest, we hear our mini lecture, Sex, Language and Sexual History Taking for Women Living with HIV. It's going to be provided by Ms. Harriet Langanke. You're welcome.
Hello, everyone. I'm Harriet Langanke, and I feel very honored and pleased to be here with my presentation on sex, language, and sexual history taking for women living with HIV. Let me start with a few words about me as a person so that you know who you are listening to. My name, Harriet Langanke, you already know. I'm based in Cologne, Germany. That's why you see behind me the River Rhine. I'm a sexologist with a special interest in women and sex workers' clients. I'm a journalist with a special interest in sexual health of women. For example, I'm the editor-in-chief in Germany's first and only magazine on women and sexual health. It's called The Diva, and you can see the HIV in the center of its name. And I'm professionally working in the field of HIV since 1991, which is quite a long time, and which has always been with a clear focus on women. Give you a short overview of what you're going to hear. I want to ask the most important question: why does it matter to talk about sex in a clinical setting? Why do those discussions matter? And what do they have to do with the sexual health and rights of women living with HIV and their well-being? I also want to address the question, what is it that makes it so challenging talking about sexuality? And you already can see here the first barriers that I'm addressing. It's, of course, stigma, shame, it's cultural norms, and very important, the fear of judgment. And I'm trying to address the how, the modalities, how can clinicians and health professional staff as a whole, how can you and they address sexual health matters in a safe, open, respectful dialogue. The first take-home message I want to give you is that it is very important to understand your own beliefs, because what we believe will be mirrored in our talking and what we say, and our patients will understand or at least get the message of how safe and how confident we feel ourselves talking about sexuality. So it's clearly proven that our morals, our ethics, and our personal beliefs really shape how we talk about sex, how we discuss sexuality. And if we are not aware of our own beliefs, they will still show. So it's best to have a reflective practice, because without reflecting it, we may impose judgment to our patients. We would probably discourage openness and create the power imbalance, or if we don't create it, we just contribute to the existing power imbalance. So if we reflect our own beliefs, this helps to identify our own biases. It helps to align with our ethics and the ethics of the patient, and it fosters comfort for discussion about sexuality. Talking always means that we need to use some sort of language, and using a proper sexual language is something that many people feel not very comfortable with. So if you read these words on the slide, as they go: respectful, inclusive, non-judgmental, cultural sensitive, this is very abstract, and it needs to be trained, and it needs to be reflected upon. What does this really mean? And for healthcare professionals, it means in the first place that we use a correct anatomical and sexual terminology. I don't know how often I have encountered in a medical context, in a clinical context, mixing up very basic vocabulary. For example, vulva and vagina. People do not seem to understand that this is two different things. And even though they are medically trained, they still use them wrongly. So if you start discussion on sexuality and health, make sure that you are familiar with the correct anatomical and sexual terminology, and that you avoid vague terms. For example, you could address the genital region just by staying very abstract and vague without addressing or using the proper names, and or do not use euphemisms. Normalize talking about sex by embedding it in your routine care. And there is guidelines available by EACS and IAS, the International AIDS Society, and the European AIDS Clinical Society, which is called People First Language: how to avoid stigmatizing terms. And there's just a few examples here that you'd rather not say a person is HIV infected, but the proper wording would be people living with HIV. And words like victim, failure, or carrier, virus carrier, become very clear that they are stigmatizing and showing some bias, which, if you reflect on your own beliefs, become very clear as stigmatizing and problematic. So using proper sexual language is something you can prepare. However, you might want to make sure that your patient is understanding what you are talking about. So make sure that the proper sexual language is understood by the patient. Taking sexual history for women with HIV requires, in the first place, the answer to the question, why? Why would you be interested in her sexual history? Why is it important? How many partners she had? What is the gender of the partners? What is the sexual health status? Be very careful, that's my advice, to ask those questions when you cannot give a good reason for asking them. If there is a medical necessity to learn about the sexual history, tell the patient what is the reason that you are asking these questions. Otherwise, they would get the feeling that you are just curious or that you are judging her. So therefore, I would really recommend that you answer in the first place the question, even if it if the patient does not ask the question, why do you talk with her about this? You better share with her your reasons. So when I prepared this presentation, the 5 Ps came up, and see as a guideline or a framework, talking about partners, about practices, about protection, past STIs, and any plans for pregnancy or existing pregnancy. This is just a guideline to help you to remember what questions you can ask and what topics you can address. But I would really recommend that you always answer for yourself and for the patient, why are you addressing these issues? And you can see that I'm coming with some tips for being respectful and for being open, and that questions and mirror the patient language. Of course, not if there's misconceptions within the patient's language, but just to be sure that you're both knowing that you understand each other. What is an open-ended question? Open-ended questions are questions that usually begin with what would be in English a W or an H question. So regarding the partners, you would probably ask the questions, how many partners do you actually have in your sexual life? And this gets me back to the little change that I made in the slide. I added not only the sexual history, I added to the sexual history also the presence, because the presence sometimes is more important than the history of women living with HIV. So when you ask the question about the gender or the HIV status, and when you talk about practices, leave the answer to the patient, offer several answers, and be as open as you can be. So, for example, do not ask closed questions like, do you use condoms when you have sex? But a more open asked question would be, what kind of protection do you use when you do have sex? Or not asking a person, do you have any pregnancy plans? Or actually, it's helpful to ask the question and to put the question in a way, for example, what are your plans regarding family, regarding having kids? So this is about taking on the history. I repeat that it's always very important to reflect on why are you asking these questions, and you should really give a good reason and embed your questioning and your discussing into the framework why you are asking this, and give a good reason. And second very important tip is you would not know if the person, the patient you are talking to, has experienced any trauma. And it is very helpful to be sensitive and very aware of this possibility, so that you could conduct the discussion and the talk you are having in a way that shows the utmost respect and sensitivity towards your patient. And when I'm put on here the words of respect for documentation, I was thinking of habit that was very long practice, and I'm afraid it still is in some settings. When I'm talking about respectful documentation, I still see those files of patients where there are huge marks in red letters like HIV or infectious. And this could be a very traumatizing or re-traumatizing effect, could have an effect on the patient. So try to be as sensitive and respectful as possible. Practical communication strategies, and I can't repeat it often enough, is once you have reflected your personal beliefs, your biases, and have investigated why you are talking about this sexuality in the medical setting, it is a very good thing is to normalize this discussion. We ask all our patients these questions, or we need the answer from all our patients. It's not just because we are talking about HIV. It's all to be seen in context with your sexual health and your sexual well-being. Listening without judgment is a very important, not only an IAS principle, but I think it's important in all medical settings. Guilt is not something that helps in increasing sexual or well-being at all. We've just been talking about trauma, and trauma-informed confidentiality also addresses the setting that we are having the discussion. Make sure that no unintended witnesses can follow the discussion. Sexuality issues are private issues in most cultures of this planet, and therefore make sure that you conduct the discussion in a very confidential, safe setting. You would probably avoid stereotypes and assumptions if you have already reflected on your own beliefs and that you know your own stereotypes so that you can avoid them. And you will probably consider intersectional factors depending on the age, the culture, or the socio-economic status of your patient. And by this slide, I wanted to remind you that I'm talking about women, cis women mostly, and that there is more issues when it comes to trans people or non-binary people, but you would consider them to be seen as women. So I also think that this comes with an intersectional with an awareness of intersectional factors. And the literature recommendation I'm giving here is from a colleague from the UK. The medical practice of silencing. It's a very, very recommendable reading, not only about sexuality and sexual health in a healthcare setting, but on the medical practice in general. So here is my conclusions and the takeaways that I wanted to prepare for you. I think discussing sexuality is central to HIV care, not only because most HIV infections in women living with HIV do have a sexual background, not all, of course, but most if it comes to statistics. So sexuality plays a huge role, not only for the transmission that led to the HIV infection of the patient sitting in front of you, but also to avoid transmitting HIV to others, which is a concern. Most women living with HIV I have met in my life, it's a huge concern of many women, and it's important that they learn about the truth of U equals U, and that they can have a sexuality, still can have a sexuality even though they are living with HIV. And one thing as a sexologist that I want to mention especially is that sex per se is a very healthy thing for all people living with HIV, and that includes women living with HIV. So the second takeaway is that I strongly recommend to reflect our own personal biases and the ability and increase our ability to listen without judgment, staying curious without being indiscreet, or if we are curious for medical reasons, we give those reasons and name them. I'd also give you some advice about using the respectful language, how to build trust, and there are lots of guidelines, and I'll show you on the next slide. I remind you to be open to your patient, to give them the reason why the structured history improves the care, and why this supports her rights, her sexual and reproductive health and rights. And continue a provider training in sexual communication, because this is something that people do not learn by just following one presentation, but this is something that needs practical training. Here's the references and resources, and they all come with a link. My personal recommendation is the WELL project that you can see here. It has the guidelines for women's health, being, and sexual health conversations. If you have any questions, I'm happy to take them.
Ms. Harriet, thank you. Thank you really very much for your very interesting presentation. It's true that questions, the issues you're discussing are important, and I agree that doctors have to start from themselves, because doctors need to be comfortable talking about sexual practices, sexual health, and really you have to understand how to correctly ask patients about those issues. So, dear colleagues, maybe Olga, do you have questions or comments? I also would like to express my gratitude. It's a unique presentation. It inspires me. Lots of practical recommendations with regards to how to discuss, how to ask questions, language, feedback, focus on feedback. You have to understand whether the person have understood what we are discussing, what we are talking about. So you have a lot of practical recommendations, how to talk, what to say, how to listen. And thank you that you focus on continuing training, because that's really important in practical, every day-to-day real practical life of every doctor. And thank you for the resources, because yes, we can look up, and doctors can look up and get more training. So hopefully, yes, we will get trained more. So thank you. Me either. Thank you, Olga, for what you have mentioned, but I would like to join in saying thank you very much, dear Harriet. I agree wholeheartedly that discussing sex is the key in providing care in HIV. That's true. And what I really also liked, that you have to learn. You have to learn how to do it. And you have to think about your own biases, as you mentioned, to reflect, because it's true. Very often we are we are very much influenced by our own perceptions. So we have our own perceptions, and the language is important. So language is not the secondary, so to say, issue, because it defines the attitudes, decisions, and also it influences choices. And if we use precise, correct terminology, language. It's not just professional communication. We identify whether it's inclusiveness, whether it's respect. That's how we show respect and how we show that we care. So I believe that really like taking such advice like you are showing, we are creating more sensitive, more open, more equitable system of care that we use for our women living with HIV. It's true. Also, I agree we have to get trained, because sometimes I can hear doctors say that a patient, yes, truly like witness this, witness that. And I'm asking the doctor, how come he or she witnessed? It's not a criminal that we are talking to. It's not in the law enforcement situation that we are in. So we don't just have to declare that we have to respect a patient. Like, we have to actually respect patients. And in our own communication, we also have to speak to and talk to other people the way we should talk to patients as well. It's just we need to change in the way we communicate among themselves. We just discussed with Olga recently, like how do we call patients? Not a patient like a person living with HIV, not to write of course, we have to write in our documentation patient, but it's a person, it's a human being. And also, I agree with Olga and agree with Sergey that it was truly that your participation in our webinar is really useful. Hopefully that it's going to be not just the first, but there'll be more cases when you will be coming to participate in our webinar. So thank you very much. And dear Sergey, please tell us if there are any questions from our participants in the chat. Yes, we have quite a lot of questions to Harriet from our participants. And the first one, Miss Harriet, the question is as follows. What are the most prevalent or frequent barriers, stigma, or fear of judgment or something else you've seen in women living with HIV in your practice, and how do you overcome them? Thank you.
Yeah, thank you for this question, and thank you for all the comments I got so far. I think a very, very big issue for women living with HIV is, generally speaking, having sex at all. So many women that I have encountered living with HIV are very, very much afraid of passing on the virus. Very many women do not really believe strongly enough that you equals you, and their feelings of being guilty of acquiring HIV and the feelings of being anxious about passing it on is a very major issue that comes with many, many women. And it's not necessarily that they avoid having sex, but they can't really enjoy it that much as if they had another information, if they truly could believe in you equals you, and that the possibility of experiencing sexual pleasure and joyful sexuality relies very much to the information she gets from her healthcare staff and her healthcare professionals. So yeah, that's the most prevalent challenge of having joyful sexuality, and it can be addressed by healthcare professionals who ensure her and them that there is a good protection by you equals you, and that they can still, even though you can address the feelings of guilt and the feelings they have, don't ignore them, they are important, but acknowledging them does not mean to continue with them. So you can help them in overcoming those feelings that keep them away from fulfilling their sexual health and rights.
Дуже дякую вам за відповідь.
Thank you so much for this answer. And the next question is actually, in addition to the previous one, how to correctly or how the best way to explain patients that you equals you to decrease their fears with regards to intimate relationship.
Yeah, the answer to this question goes very much to the professionality of healthcare staff. I think physicians, doctors are very, very good in teaching and describing how U equals U really works, and that when there is no virus found and the viral load is so low that it won't be detectable in bodily fluids that play a role in having sexuality, you can share this wisdom, you can share this knowledge with your patients if you explain to them how this really works and that this is something that is really protecting them and their partners. I'm quite sure that when you properly explain it, that this will be understood. It's not a matter of just believing that this is true, but you still can prove it. You have the statistics at hand. We know that it works, and your patients can rely on you here, hopefully.
Дякую, пані Гарріет.
Thank you, Ms. Harriet. We have just time for one more question, and then we will go on to our next lecture. So this is a question, and also there'll be more discussion after all the lectures. Yes, that's true. So the question is as follows. This is about 5P strategy or approach 5P, how it's better to implement it in your day-to-day practice, not for it to be formal or maybe even threatening the patient. What's the best way?
I think it's a very the answer requires a very individual approach. The 5Ps are just a sort of help because we have 5 fingers. It's easier to remember 5 points. So not all of them are important in the same setting to the same persons. It's just that it's just a helpful tool to remember what of those 5 Ps are the Ps that are relevant in a certain setting and for a certain consultation your patient is having. It's not to be put on a wall and work through it. It's just a helpful tool to remember whether, am I talking about sexual practices here? Do I need to inform about the protection? Is it more about the pregnancy plans or so? So it's just for me and for others, I have learned that just a helpful tool to have it at hand and not to be very dogmatic about it, just to use it as a framework in which you can act more confidently.
Дякую.
Thank you very much. Thank you, Ms. Harriet. I have a feeling, I feel that we need training. Dear colleagues, what do you think? Ukrainian colleagues, do you think we really need to have a training because we need to learn how to communicate? I'm not saying that we cannot communicate. Of course we can, but we want to improve. We want to be better. We want our communication to be better than now. So thank you once again. Yes, thank you. That's true. Training is something that we all need. We will think how it might happen. And what I mean, all Ukrainian doctors, I don't mean just myself and us present here, but all doctors in Ukraine. Of course, Ms. Svetlana, all right, dear colleagues, I suggest me moving on. We have lots to do. So now mini lecture about HIV and women on track to a healthy and long life Ukraine. Olga Klimova. Greetings, dear colleagues. To me, it's a great honor to present information about results and challenges related to HIV in women. For many years, our country has been building up HIV response, and in the last 3 years, this work has become even more difficult due to large-scale invasion. But even in such difficult, extreme situations, we continue to work to provide access to prevention, treatment, and care to women. The topic of my presentation, Women and HIV on Track to Long and Healthy Life Ukraine. And I'm going to show you key data depicting our situation, achievements, as long as challenges still need to be resolved. I have no conflict of interest. Traditionally, let us have a look at statistics looking at treatment cascade for HIV-positive women and girls. This is as of the 1st of January 2025. The data is represented by women and girls of all age categories. So, estimated number of HIV-positive women in Ukraine is 95,735 persons. 64% of that estimated number of HIV-positive women, which is 61,547, know their HIV status and they are linked to care. Out of those who are linked to care, 88% of women, which is 53,946 persons, receive ART. Out of those who receive ART, 85% of women, which is 45,596 persons, achieved viral load level less than 1,000 RNA copies per milliliter. This is as of the end of the year 2024 in Ukraine. Respectively, out of those who are getting antiretroviral therapy, 80% of women have achieved full viral suppression, so their viral load level is less than 40 copies in 1 milliliter. And the next slide, we are showing in additional column. This is coverage with HIV viral load testing as of the end of the year 2024. Out of those who receive ART, 47,243 women, which is 88%, have undergone HIV viral load testing. So we are not reaching our target 95% with regards to HIV viral load testing coverage. But out of those who has the result of viral load testing, 97% of women, which is 45,596, have achieved viral load level less than 1,000 copies in 1 milliliter, and full suppression was achieved by 92%, which is the viral load level less than 40 RNA copies in 1 milliliter. And next, what I would like to show you is the age breakdown of women living with HIV by age. Out of all people living with HIV and linked to care, as of the end of 2024 in Ukraine, 45% are women. This is almost half. So the absolute number is 61,547 women. And respectively, according to age structure, women from 25 to 49 years of age, 73%, which is 44,999. So their most active period of time, and when they are mothers, when they care about their family, is this group of women. And among all people living with HIV and who were linked to care first time and diagnosed with HIV in 24 in Ukraine, women were 35%, and the absolute number is 3,465 women. And respectively, 67% of women are women aged from 25 to 49 years of age. If we look at more detailed breakdown by age among all women and girls aged 15 and plus, we can see that the number of women from 30 to 49 years of age is 61%, which is 2,108 women. And now let us have a look at annual statistics in Ukraine with regards to pregnant women and babies. And this table shows that the number of HIV positive women who got pregnant is decreasing year to year. Namely, in 2016, the number was 2,814 persons, but it's been 1,000 less registered in 2021, which is 1,857. 800 less was registered last year, 1,083 women. Number of deliveries in HIV-positive women is decreasing as well. In 2021, it was 1,904 deliveries were registered. Last year, 2024, 1,122 deliveries registered in HIV-positive women. So we see that in the last year, the number of deliveries in HIV-positive women is bigger than the number of registered HIV-positive women. That's related to the fact that some HIV-positive pregnant women were registered and linked to care in previous year, 2023. And down here on the slide, we can see the pie diagram with breakdown of HIV-positive babies linked to care. This is as of the end of 2024. In other words, we can see that more than 50% of this category of babies were linked to care in 5 regions, which is Dnipropetrovsk, Odessa, Kyiv, Donetsk regions, and the city of Kyiv. So totally, as of the end of 2024 in Ukraine, 1,269. Unfortunately, last year we also registered 6 babies with HIV-positive status as per the results of early PCR NET testing. And then we can talk about ART in pregnant women with HIV. Annually, 1/3 of women learn about their HIV in pregnancy and they start treatment respectively. Up to 70% have already been getting ART before they got pregnant. The positive thing is we see decrease in the percentage of women who start ART intrapartum. Last year, this percentage was 2.7%, but unfortunately, still we have a certain percentage left. In last year, it was 2.6%. Those are women who either did not get ART or we didn't have any data about them. But the positive thing is that we see stable percentage of women who continue ART after delivery. And last year, in 24, almost 97% of women continued their treatment after delivery. And the main goal of treating pregnant women is complete HIV viral load suppression before last trimester of pregnancy and especially before delivery. Antiretroviral therapy initiation in the 3rd trimester is associated with unfavorable outcomes and increase in HIV vertical transmission rates. At the same time, safety is important, which is minimizing risks for women and babies. In Ukraine, only 30% of pregnant women learn about their HIV diagnosis in the 3rd trimester, and 7% learn intrapartum or postpartum. So this data show the problem in general with regards to late presentation to get obstetrical and gynecological care. And next, what I suggest is to look at treatment for all adults in Ukraine as of the 1st of April 25. In our country, the approach is the same with regards to treatment prescription. It's regardless of gender. So as of the 1st of April 2025, antiretroviral therapy was received by 110,499. 95% out of them, 104,582, were getting tenofovir-based regimens. 4%, which is 4,507, were getting abacavir-based regimens, and 1%
which is 1,410 persons, were receiving zidovudin-based regimens. And additionally, 51 patients were on regimens without NRTIs, and 355 patients were on 2-drug regimens with lamivudine. And now let us have a look at the third ARV drug within the regimen among the same number of adult people who were receiving ART as of the 1st of April 2025. So we can see 89%, 98,708 persons who were getting regimens based on InSTEAM. Among them, 98,708 were getting dolutegravir-based regimens, and 198 were getting raltegravir-based regimens. 9% of adults, which is 10,065 persons, were getting efavirenz-based regimens, and 2% of patients, which is 1,935 persons, were getting protease inhibitor ritonavir-based regimens, and among them 1,210 patients were getting lopinavir-based regimens, lopinavir plus ritonavir. 423 were getting atazanavir ritonavir-based regimens, and 32 patients were getting darunavir with ritonavir-based regimens. As of today, patients who were getting lopinavir atazanavir-based regimens already are being switched to darunavir-based regimens. So validation elimination of vertical transmission is still very important achievement that we have to achieve, and regardless of the war, so Ukraine is still achieving the targets. So the HIV vertical transmission rate as of the PCR net data was 0.5% last year. So 6 babies with HIV positive status were diagnosed based on PCR testing. Antenatal care services coverage for pregnant women was more than 99%. HIV testing coverage for pregnant women was more than 88%, ART coverage for pregnant women we are keeping on the level 97% in 23 and 24 years. HIV viral load testing coverage for pregnant women prior to delivery last year was 92.8%. PCR net testing coverage for HIV-exposed babies last year was 99%, and post-exposure prevention coverage for HIV-exposed babies last year also is almost 99%, and it was in 23 and 24 almost 99%. So now I would like to sum up, to give some conclusions. So in Ukraine, of all people living with HIV today, proportion of women is 45%, almost half. As of the 1st of January 2025, 61,547 women know of their HIV status. In 2024, newly diagnosed and registered within the healthcare system or linked to care 3,442 women with HIV aged 15 plus and older. And the breakdown by age categories is as follows. 15 to 49 years of age, 2,445 women. Age group 15 to 39, 1,333. And number of women aged 50 plus is 997 women. And among women living with HIV in Ukraine who know their status, the prevalent group is women aged 25 to 49. So the proportion is over 71%. 53,946, which is almost 88% women living with HIV who know their status, currently getting ART. which is over 7.5 thousand women living with HIV who know their status and are not on ART. We are not reaching the target 95%. Coverage with HIV viral load testing of women on ART in 2024, 88%. And the reasons are war, also forced displacement of population, logistic challenges, etc. So the best estimate for undetectable HIV viral load is confirmed in 80% of women on ART as of the 1st of January 2025. We have not achieved this target, which should be 95%. And out of those 47,243 women on ART who have access to HIV viral load testing, 92% it achieved undetectable viral load. In 2024, 1,122 women living with HIV gave birth to babies. According to early NETS diagnostics, PCR diagnostics, 6 babies were diagnosed with HIV. Over 2024 total, according to cohort analysis, 23 babies were registered. Those are HIV-positive girls. 1/3 of HIV-positive women who gave birth to babies in 2024 were diagnosed with HIV first time during pregnancy. After first trimester, unfortunately, in 70% of them, during third trimester, 14% were diagnosed and 2.7% were diagnosed intrapartum. And regarding 2.6%, there is no data with regards to ART. 96.8% of women who gave birth to babies in 2024 continued ART after delivery. So in summary, regardless of all challenges caused by war, like forced displacement, challenges in logistics, lack of resources, Ukraine continues to provide access to essential care for those who are in need the most, and special attention is given to women and babies. Conditions are being created to preserve their life and health so that they can feel protected even in the most difficult circumstances. At the same time, we recognize and acknowledge that the system needs further development and improvement to make care even more efficient, accessible, and focused on the needs of each person. Thank you for your attention, and thank you for having this opportunity to speak in front of you. And we are thankful to all the partners for all their support that they're giving to our country, and especially in these difficult times. We'll be happy to answer any of your questions.
Dear Olga, it's impressive. Yeah, your presentation is truly impressive. We can see how much effort do you make and the agency you work make, your colleagues, in order to provide access to essential care for women in so difficult circumstances, to save their lives, to save their health. More than 60,000 women living with the HIV in Ukraine, which is 45% of all people living with HIV in Ukraine. So this is the peculiarity of our situation. And more than 1,000 women gave birth to babies in 2024. So again, regardless of war, regardless of the difficulties of times, and more than 3,500 women were first diagnosed in 2024. And all these women need help to provide ART. Also, we need to provide viral load testing, and so on and so forth. So it looks like your presentation will be requiring even more attention. And because you have lots of statistical data, it's going to be really interesting for EX, WAVE, and other agencies, I believe. So thank you once again. The only thing that I would like to add, I would like to thank all our doctors in Ukraine who work under such circumstances, because it's thanks to them, thanks to their daily lives, that we have these statistical data from them. So thank you. That's true. That's true. You are right. Absolutely. It's all doctors and it's all of us, but still your presentation is wonderful. I insist. I insist. Thank you. Thank you, Ms. Olga. Ms. Mariana, maybe you have comments or questions? First thing, I also would like to sincerely thank Ms. Olga, wonderful presentation, lots of statistical data put together. And there is an order of the Ministry of Health, and number 1337 about pregnancy in HIV. So any woman, regardless when it started to be monitored, so has to be tested for HIV, syphilis, and hepatitis. So that's mandatory. And usually women agree to all that testing. And some people learn about the HIV status intrapartum, but the majority of them learn it before. So, and every doctor tries to do the best way and to offer all the necessary testing. Majority of women still learn their HIV status from first to second trimester, but a good thing that we still have enough time to prescribe ART to prevent vertical transmission. And right away, we also choose the delivery mode depending on viral load and depending on the duration of ART. And maybe just a few words more. So when in the beginning of an antenatal care, there is HIV test, then 20 to 23 week of gestation, and there are some groups of population that would require third testing. So it's written in our orders, Ministry of Health. And another thing to add with regards to that presentation, in the majority of public healthcare facilities, there is an ethical code implemented to decrease stigma and discrimination towards such patients. Lots of doctors know about that, and we try to communicate, to talk, and to care of that patient in a way for them to feel comfortable and to come to us again. So thank you once again. Also, I would like to add as well, we need practical training from Harriet. Still, we need it, Harriet. Yes, because we want to improve and improve. Yes, that's true. And yes, and our participants in chat agree to that. Ms. Harriet, do you have any comments with regards to Olga's presentation? Would you like to say something?
Yes, I would really love to say thank you. And I learned amazing things about what you achieve despite the terrible conditions you are working under. So it's really amazing what you showed. Thank you so much for that. I was learning from your presentation that you also have something that you called late presentation. And we have had this in Germany as well, and I think in other countries as well. However, we learned that many women do present themselves and their symptoms to doctors, but mostly to general practitioners or to gynecologists and not to HIV specialists. So we wonder if we could learn, or I wonder if we could learn from you how you address this issue, because in Germany we find that many GPs, many gynecologists are quite ignorant for those symptoms, and they are quite ignorant when it comes to HIV. This is partially due to a complete different epidemiological data we have in Germany. I learned from your presentation that the percentage of men and male and female patient is almost equal in Germany. It's 80% men having sex with men being diagnosed. So can I learn from you a bit more about how you increase awareness under medical staff, gynecologists, for example, for issues like HIV?
Дякую, дуже гарне запитання.
Thank you. Very good question. Truly, as I mentioned, problem of late presentation is something that we do have. But with regards to HIV testing for pregnant women, what I want to say, as you saw, we have a very good percentage. 99% are tested, undergo HIV testing. And we have our standards, they are approved, and doctors have to observe that. So when a woman is linked to care, so is tested, then the second testing, and right before the delivery. If a woman presents for the first time before the delivery and we don't know about how was everything during the pregnancy. For example, if she moves one place to another to deliver, nevertheless, even intrapartum, she needs to be tested. So testing is mandatory, and all doctors, they know those pathways, so what to do in which cases. So if there is no HIV test result, then the testing is done, and depending on the test result, so they know what to do. For example, what baby needs to get, for example, in order to prevent neonatal infection. So maybe Ms. Mariana will add something on top of that with regards to pregnancy management. For example, because sometimes in regions, doctors present for the first time right before the delivery. So how gynecologists help these women to get tested? But from the medical point of view, we have the standards which are approved, and we have to do that, to observe them. Thank you, Ms. Olga. Just a couple of words. Even if there is some percentage of women that were not linked to care, who move from city to city or just move all the time, live here and there during delivery, it doesn't matter which healthcare facility they go to the admission ward, and in each hospital in admission ward, they have rapid HIV tests. They all have it. So always rapid test, HIV testing is done. And as per the results of this test, we do. If it's a positive result, we prescribed antiretroviral prophylaxis intrapartum. We have such drugs. Maybe it's not, might not be in the facility, but there is an agreement signed of this healthcare facility with some other infectious disease hospital or something, so they share. So in other words, we have all drugs for prophylaxis, and we practically do not have women who wouldn't agree to get tested intrapartum, so they usually agree. Sometimes it happens that, for example, she was linked to care somewhere, but we don't have access to electronic system, and she comes without paperwork. Still, we do the rapid HIV testing because we don't have the information on hands. Thank you very much, Mariana, for what you added. Thank you, Mariana. Yes, truly. Svetlana, what do you think? Yes, what I can say. Yes, again, thank you. Thank you very much. Just I wanted to ask all of us, what do we do with our agenda? Yes, because time-wise, we are kind of behind, but still we have one more mini lecture planned about the reproductive health status in Ukraine. So there's two ways that we can go. It's either we can just put it online for people to watch, because Ms. Nadia is not with us, unfortunately, or we watch it and then discuss it. But in this case, we will be quite late to finish. So dear colleagues, what do you think? We basically have only 6 minutes before the end of our webinars. We've already mentioned nice words to each other, that it's a great pleasure for us to be, and we finish with nice words, or 20 minutes, another lecture, and then we will say warm words to each other. What do you think? We are flexible. So we can put this lecture in YouTube for people to watch. Well, you know, dear Svetlana, we will probably, that's what we will do. We will just put Miss Nadia's lecture on YouTube for everyone to watch it in their free time and not to waste time now. Maybe it's just, we have 5 minutes or maybe 5 to 6 minutes for final comments, nice words, and final goodbyes, right? So who would like to be the first?
Маріанна, Ольга,
Mariana,
Гаррія.
Olga, Harriet, Sergey, myself.
Давайте, напевно, я скажу.
Let me say first, please. First of all, once again, I really would like to express my gratitude to Ms. Svetlana for invitation. Second thing, yesterday and today we discussed really important topics, important for every woman living with HIV. I'm sure we had lots of women living with HIV listening to us. They received quite a lot of information about contraception. That's really important topic for these women because sometimes they're shy to ask. It's not always that they can come to see an OBGYN. And it's not always that they can be open to openly share their problems. So wonderful that we've discussed that. So thank you once again. I would like to add on top of that. Yes, I also very much grateful for this opportunity to be part of this conference. Thank you very much to Harriet for very interesting presentation, for practical recommendation, practical tips and advice. And thank you for agree to continue to work with us in future for us to get more knowledge about that. Also, I'm very grateful to Caroline because we've received very interesting information about reproductive health. And in general, it was really joyful to speak to each other, to share our data. And we see that we are not sitting at the same place, being at the same place, but we are moving on. And to share that, it's wonderful to have a platform like that for us to share. So Ms. Harriet, Ms. Caroline, and everyone else, thank you very much again and see you next time. Ms. Mariana, Ms. Olga, thank you for your comments. Ms. Harriet, maybe the last message to our participants. And there was a question, I think, to Ms. Harriet, I think, in the chat. So whether we need to involve non-governmental organization workers into training for them to share with us how it's comfortable with them, so how we should communicate with them. So sorry to intrude, but there was a question in the chat about that too.
I would rather not take it as a question, but as a real recommendation, because I think networking is key here. We can all learn from each other so much. And therefore, I think it's crucial to stay in collaboration, and whether it's NGOs or activists or communities of living with communities of women living with HIV, being in contact with them and learning from them what language they prefer, what questions they do have, and especially what they do not understand in the first place when it comes to talking to a doctor. So yeah, please get in contact with them. Please allow them to ask their questions and ask them your questions as well, because it's mutual. It's not just a one-way road. It's collaboration and mutual respect. And I'm just going back to say from my side a huge thank you for having me. It was a great pleasure and a great honor to be with you. I always learn so much when I meet people and specialists like you from other countries. Thank you for so much information I did not have before, and for having me. And as I said in the chat, I hope to see you in real life, not only on screen. And I see that some of you will be in Paris. I'm very much looking forward to seeing you. Thank you again.
Дуже дякую, пані Гарріет.
Thank you really so much. And I would also like to say, likewise, thank you very much to Mariana, to Olga, to Harriet, to Caroline, everyone, all participants of our webinar. And I'm very hopeful that we will see each other in Kiev. In Kiev, we will visit our opera and ballet theater named after Taras Shevchenko. We have a beautiful, wonderful opera and ballet theater, wonderful, excellent ballet, excellent. I'm sure that we will welcome you here in Kiev, see you and welcome you in Kiev. Thank you from the bottom of my heart. It's really interesting. We believe in multidisciplinarity. We are forming it, we're building it, and we are showing it. It's important to communicate between different specialists, community representatives, journalists. Yes, Harriet, sorry, and activists. Yes, people who protect women. For us, it is really, really important. So that is why see you next time. And again, big thank you. Thank you, Svetlana. Truly, dear speakers, you were incredible. And I would like to remind a couple of more things to our participants. Soon, the survey is going to be available. Please fill out this survey to get the certificates of your participation in our webinar after you fill it out. So once again, thank you and see you next time in May 2026. Goodbye. All the best.